This podcast is sponsored by Zoll LifeVest. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey everyone, this is Amit Goyal. Welcome back to a CardioNerds case report. Today we get to hang out with new friends and learn all about cardiology from Duke University, Doctors Belal Suleiman, David Elliott, and Nkiru Osude. Y'all, welcome to the show. Would you please introduce yourselves?
Of course, I can begin. Hi, everyone. I'm Nkiru Osude. I am from the best city in the world, also known as Chicago. I completed both my undergraduate and medical degree at the University of Missouri in Kansas City. Following med school, I went back to the Windy City to complete my residency at Loyola. And then after residency, I stayed on as a chief medical resident where I oversaw all of our inpatient rotations at the University Hospital. During training in Chicago, I obtained a master's in healthcare quality and patient safety at Northwestern. And I am currently a third-year cardiology fellow at Duke. And I just started 2 years of research, which I'm doing at the Duke Clinical Research Institute, or the DCRI. I'm clinically interested in general cardiology and cardiovascular imaging. My research interests surround using health policy dissemination and implementation research to decrease disparities in cardiovascular disease burden. And when I'm not in the hospital or on the computer doing research, I enjoy working out, cooking new recipes, trying new restaurants, traveling to visit family and friends, and lastly, I love music. You can find me at musicals, concerts, local live performances. I recently just went to a live album recording, which was pretty fun, and I'm really happy to be here with you all.
Hey everyone, I'm Belal Suleiman. I was born and raised in Lexington, Kentucky, the horse capital of the world, and where from a very young age, I was taught to cheer on the best basketball team in the country, the Kentucky Wildcats. I studied at the University of Kentucky for both undergrad and medical school before venturing out to the University of Texas Southwestern in Dallas for internal medicine residency. Along the way, I met amazing teachers and mentors that made me fall in love with cardiology. I am now at Duke University, where I'm in my second year of training with a plan to study all things heart rhythm related during electrophysiology fellowship. I'm interested in studying the changing epidemiology of ablation as we've entered the modern era of guideline-directed medical therapy and patients are living longer with heart failure. When I'm not at work, I'm spending time with my wife and 2 kiddos, playing soccer, riding my bike on one of the various bike trails in Durham.
Hey guys, I'm David Elliott, a South Florida native. I made the trek up to the University of South Carolina where I did my undergraduate work. And then I took a deep dive into immunology when I completed my PhD in biomedical sciences. In an attempt to further evade the workforce, I then came to Duke University for med school and then residency training. Now I'm a current second-year cardiology fellow. I'm hoping to specialize in advanced heart failure and transplant. I'm deeply curious about the crossroads of cardiovascular disease, metabolism, and immunology. And away from the hustle of research in the hospital, I'm spending quality time with my family or cheering on Manchester United. Excited to discuss this case today with you all.
You guys, this is so great. We have so much expertise and knowledge power on this episode between EP and imaging, health policy, metabolism, immunology, heart failure, and then intervention for myself. I can't wait to get on with the show. But before we get down to business, where are we going to hang out?
I think we've taken you guys to a couple places in the past, but today let's explore the American Tobacco campus. It's in the heart of downtown Durham. It's made up of these repurposed tobacco warehouses. So they've made them into shops, offices, cool restaurants, fun places to hang out. And it's just a great place to grab a bite or even just kind of wander around. Also, since it's the summertime, after we're done eating, we could catch a Durham Bulls game.
That sounds awesome. Let's get right down to it. Tell us about your case.
Of course, our gentleman is a 45-year-old male with a history of uncontrolled type 2 diabetes. His last A1C was 9.2. He has hypertension, dyslipidemia, and his cardiovascular history actually began when he had a UTI that resulted in endocarditis. His endocarditis was complicated by septic emboli phenomena to his lower extremities. His endocarditis ultimately required mechanical mitral valve and aortic valve replacement in summer of 2022. His post-operative course was complicated by complete heart block, requiring a dual chamber pacemaker. After discharge, he was admitted 3 different times in the following month for volume overload to what was thought was presumed to be a heart failure exacerbation. The patient was understandably concerned and decided for his next admission for heart failure, he would be evaluated at another institution for a second opinion.
Wow, Kiki, such an unfortunate set of events for this patient. To summarize, we have a middle-aged man with a history of endocarditis of the aortic and mitral valves, for which he received mechanical valve replacements. His post-op course was complicated by complete heart block, requiring implantation of a permanent pacemaker, and is now presenting with recurrent heart failure despite escalating doses of diuretics. This presentation is teeming with potential etiologies for his decompensation. When thinking about the etiology of a patient's decompensation, I like to take a systematic approach to identifying the trigger for a patient's decompensation. I like the failures mnemonic to ensure I'm being comprehensive when evaluating every heart failure patient. A few important points in general, and for our patient in particular. F is for forgot medication, and medication adherence is something I always think about. In particular, medication cost and the ability of each patient to afford their medications is something all patients should be screened for. With modern-day guideline-directed medical therapy, patients on all available therapies are prescribed 5 medications if you include diuretic therapy for heart failure alone. As we all know, patients with heart failure typically have multiple comorbidities that require additional therapies, which can quickly balloon their list of medications into the double digits. This can be challenging for some patients to afford, even if the cost of each medication is as low as $5 per month. As we move along in our mnemonic, A is for arrhythmia. Both atrial and ventricular arrhythmias, like a high burden of PVCs or non-sustained ventricular tachycardia, are important to rule out. I also like to include pacemaker function in this category as well. In particular, for our patient, he has a history of complete heart block with a dual chamber pacemaker. It would be important to interrogate his device and ensure proper function. We can also leverage the device's arrhythmia detection capability to look for abnormal rhythms that the device has detected. In those with cardiac resynchronization therapy devices, ensuring there is appropriate biventricular pacing is also important to optimize a pacemaker's function. As we round out the list of our mnemonic, we have I for ischemia and infection, L for lifestyle, which can include dietary habits and illicit substances, U for upregulation of cardiac output in high output states like anemia, R for renal failure, and E for embolism. I like to add an S to the end of the mnemonic, which I use to mean structural. And with this, I think about valve disease. Any stenotic or regurgitant valve pathology can cause progressive volume overload. And with this patient in particular, we have 2 recently implanted heart valves, which carry with them a particular set of potential complications. David, can you tell us about what we should be looking for with regard to prosthetic valve complications?
Yes, there are a number of complications that can arise in a patient with prosthetic valve. Patients can develop valve thrombosis, which can either occur at any time relative to the time of implantation, or pannus formation, which is typically a later finding. This complication can present as dramatically as cardiogenic shock due to valve obstruction, or it can be asymptomatic if the valve is still operating appropriately. Paravalvular regurgitation is another complication that can occur. This is the backflow of fluid around the outer ring of the mechanical valve. This complication has prognostic value for the patient, as many studies have shown that there are poor outcomes in those with significant leak. Typically, this is diagnosed with either transthoracic or transesophageal echocardiography. Hemolysis in patients with prosthetic valve can be a clue that either paravalvular or valvular regurgitation is present. Lastly, we all know that prosthetic material in the body has a propensity to become infected, and endocarditis should always be on our radar in a patient with prosthetic valves. Generally, these complications can be seen in both prosthetic and mechanical valves. However, we would expect it to be more likely to see thrombosis in mechanical valves and hemodynamic changes to be seen in prosthetic valves, such as stenosis and regurgitant pathologies. Well, this patient sounds like he's had quite the course, and there's a lot of potential complications to think about. Let's talk about his vitals. His heart rate was 105, blood pressure 109/76, a respiratory rate of 35, and he was satting 98% on room air. His exam was notable for an irregular rhythm. He had an elevated JVP just below his mandible. He had a harsh holosystolic murmur at the right upper sternal border with a mechanical click. And there was also a holosystolic murmur at the apex as well. There were bilateral crackles, as well as decreased breath sounds at the lung bases. He looked like he was working pretty hard to breathe. It was also notable for jaundiced appearance with scleral icterus, and his extremities were cool to the touch.
Thanks, David. Now, his labs were quite interesting. Notably, he had a sodium of 131 and a potassium of 2.8, chloride of 90, and a BUN creatinine ratio of 48/1.6. His creatinine was 1 week prior when collected by his prior providers. His high sensitivity troponin was 62 and 61 on repeat. David mentioned that he was jaundiced, so LFTs were obtained and demonstrated an AST/ALT of 56/18, and his alkaline phosphatase was normal. Interestingly, his total bilirubin was 6.8 and was predominantly unconjugated, with an unconjugated bilirubin of 5.9. His INR was 4.8. He presented with a leukocytosis of 14.1, a hemoglobin of 8.9 when previously 10.1 the week prior, and a platelet count of 235. His LDH was 999 with an undetectable haptoglobin. His NT-proBNP was 4,700, which is the highest it's been since his valve surgery. His lactate was mildly elevated to 2.8, but on repeat, it had been normalized to 1.7 a few hours later. His EKG demonstrated an atrial sense ventricularly paced rhythm at a rate of 89. In his EKG, he had several PVCs, which makes sense given his very low potassium level.
All right, guys, there's quite a bit of information to unpack here. The first piece of information that I notice is the tachycardia. We know that sinus tachycardia is a poor prognostic marker in patients with heart failure. His ECG shows mostly atrially sensed sinus rhythm with ventricularly paced conduction. He's quite tachypnic with increased work of breathing, and it's important for us to think about respiratory support with BiPAP while we rapidly decongest him with loop diuretic therapy. Another important piece of information to note is the coolness of his extremities on exam. This really gets my attention, as now I suspect he falls in the category of profile C heart failure with evidence of volume overload and poor perfusion. In this category of heart failure, it's important to think about inotropic support and even considering temporary mechanical support if the patient's clinical course fails to improve or worsen. Now his labs. There's an acute kidney injury, elevated NT-proBNP, and mildly elevated LFTs. This is consistent with what I would expect in a patient with decompensated heart failure with congestive hepatopathy. But then I see a worsened anemia with significant bilirubin elevation in the setting of an elevated LDH and undetectable haptoglobin. And now I'm concerned there is something not so common about his presentation, as these labs point towards a hemolytic anemia. In a patient with prosthetic valves and hemolytic anemia, I'm now concerned that we could be dealing with a prosthetic valve complication with either significant valvular or paravalvular regurgitation. In the chest X-ray just came back and shows bilateral pulmonary edema, a left-sided pleural effusion, and cardiomegaly with mechanical aortic and mitral valves present. Now, a few things I'm concerned about with this patient. One, complications of mechanical valves. Additionally, with his atrially sensed and ventricularly paced rhythm, I'm concerned there could be some element of pacemaker-mediated cardiomyopathy. I'd be interested to see what his echocardiogram shows. David, can you walk us through what we found?
Certainly. His transthoracic echocardiogram was notable for a normal left ventricular function with an EF greater than 55%. There was mild left ventricular hypertrophy and mild RV dysfunction. There was trivial pulmonic regurgitation. It was notable for severe tricuspid regurgitation with hepatic vein reversal and a calculated RVSP of 50 millimeters of mercury. His mechanical, mitral, and aortic valves were interrogated in particular. His mechanical aortic valve did not have any significant regurgitation, and it had normal gradients. Notably, his mechanical mitral valve had trivial regurgitation. It was noted to be well seated and had a peak gradient of 18 millimeters of mercury and a mean gradient of 8 millimeters of mercury. However, paravalvular leak could not be ruled out due to flow masking on the chest wall echo.
Thanks, David. Now let's digest this echo a bit further. When reviewing the echo findings in someone with a mechanical prosthesis, I enjoy reviewing it in a systematic way. First, it's always helpful to evaluate a baseline echo and the operative report to know the type of valve that was implanted. Once you have that information, then review the native valves followed by the valve prosthesis. I specifically look at different parameters that will help us ascertain if there's prosthetic valve dysfunction. We will be looking at the peak velocity across the valve, followed by the VTI ratio, next the pressure half-time. It's important to recognize that these numbers cannot be evaluated in isolation, but the other information you need to know is heart rate, blood pressure, and body surface area. Okay, now let's break down this echo. This was our first echo at our institution, so we are unable to visualize the prior images. First, his EF is normal. That tells me that a reduced EF is not the cause of his recurrent heart failure admissions. His severe TR is something I would not expect, but can happen when the ventricular lead traveling through the tricuspid valve impinges on one of the leaflets and restricts leaflet motion. Looking at our gentleman, it appears as though the septal leaflet was restricted. Next, I look at the new mechanical valves that replaced 3 months prior to arrival. I would expect low gradients, and with the aortic valve, that's what we see. Let's look at the mitral valve. His peak velocity was 2.1 meters per second. This is not normal and plants a seed in my mind that there may be something going on with his mitral valve prosthesis. However, as we all know, gradients and velocities can be affected by things such as anemia that cause high output heart failure. So we need more information. Let's continue. Next, I look at the differences in the amount of flow going across the valve. Remember the continuity equation. I would expect the same flow going through and across the mitral valve to be the same as the blood flow going through and across the LVOT and out and across the aortic valve in the absence of valvular pathology. In order to evaluate this, you can do a VTI ratio and compare the velocity time integral at the level of the mitral valve to the velocity time integral, or the VTI, at the level of the left ventricular outflow tract. I would expect these to be equal. However, in our case, they are not. The VTI across the mitral valve is 41.1 centimeters, compared to the VTI across the left ventricular outflow tract, which is 12.3. The ratio between the two is 3.3. This tells me that there is a whole lot more blood flow being in contact with that mitral valve compared to the left ventricular outflow tract. Finally, I look at the pressure half-time to help me digest the previous numbers that we discussed. If the pressure half-time is normal, this is more suggestive of a regurgitant pathology. But if the pressure half-time is abnormal, perhaps it could be an obstructive physiology. His pressure half-time was 72, which in the context of elevated gradients and an elevated VTI ratio, it has me thinking that there is valve dysfunction, and in this case, due to regurgitation. But we're not able to see that on the chest wall echo. The left atrium on this TT is obscured due to artifact, so we can't see or measure if there's mitral valve regurgitation. We are able to see a lot of flow convergence in the LV, but I don't know about you guys, I would like to see the LA a little bit more to make a final diagnosis. At this point in time, I would suggest a TEE.
Sounds like the echo lab is busy doing a case right now. However, we're in luck because the cath lab is open and we can interrogate his mitral valve by fluoroscopy. Fluoroscopy allows for the assessment of a prosthetic valve function, integrity, and the potential complications. It's also faster to obtain, and it can help discern certain types of complications. The size, position, and movement of the valve can provide valuable information about its performance. Additionally, fluoroscopy aids in evaluating the sealing and positioning of the prosthesis, within the native annulus. For this patient, we were able to visualize the prosthetic valve and its surrounding structures. We paid careful attention to the valve's opening and closure, checking for abnormalities, calcifications, or restricted motion. As for our patient, the valve appeared to be in good working order. For example, if the valve had dehisced, we might have seen something called ring rocking on evaluation with fluoroscopy.
Hey, David, thanks for doing that fluoroscopy for us. Looks like there's no mechanical leaflet failure, but it sounds like it's time for us to obtain that TEE that we discussed earlier. Before we do so, let's discuss why we need it. When imaging a mechanical prosthesis via ultrasound, there will often be acoustic shadowing, and knowing where the artifact is will help you identify which imaging modality will be most useful. We have already discussed that his echo is suggestive of a mitral valve prosthesis dysfunction, and fluoroscopy helped us visualize the normal opening and closing of the valve. This told us that perhaps the artifact on the TEE limited our ability to see the problem. Evaluation of a mechanical prosthetic valve via chest wall imaging is difficult because the left atrium is often not seen because of acoustic shadowing. And when we think about pathologies such as mitral valve regurgitation, we really need to visualize the LA to do so. Chest wall imaging does not allow us to do that. TEE, on the other hand, does. It provides great visualization of the left atrium, but the shadowing often limits the visualization of the LV. There are certain complications of valve prosthesis where TEE is very useful, such as flail bioprosthetic cusp, presence of pannus, thrombus, vegetations, abscess formations, paravalvular leak prosthesis, and dehiscence. Based upon this, Belal, let's get that TEE.
Thanks for walking us through that, Nkiru. So this patient then had a transesophageal echocardiogram completed, and that confirmed our suspicion that this patient's mitral valve was abnormal. The mean gradient across the valve was 11 millimeters of mercury, with severe paravalvular mitral regurgitation and pulmonary vein systolic flow reversal. This confirmed the findings that suggested there was mitral regurgitation on the surface echocardiogram. Now, onto the tricuspid valve. The transesophageal echocardiogram also confirmed what we saw on the chest wall echocardiogram, that the septal tricuspid leaflet was impinged, and that was related to device sleeve placement. David, given this patient showed evidence of poor perfusion on his exam, I think a right heart cath would be useful in helping us understand his hemodynamics a little bit better. Can you walk us through what we found on his right heart cath?
Certainly, always happy to help and get some invasive hemodynamics. So on his right heart catheterization, his RA mean was 17, RV 49 over 18, PA 49 over 21 with a mean of 31. There was a mean pulmonary capillary wedge pressure of 26 millimeters of mercury with a V wave of 50 millimeters of mercury. His calculated cardiac output was 3.6 liters per minute with a cardiac index of 1.7. Notably, at the time, his blood pressure was 86 over 53. So there's a lot to take from these numbers, but I think one good learning point that when you've done a physical exam on a patient who then gets a right heart cath, you should try to reconfirm your exam with the calculated RA pressure. And in this case, we should keep in consideration that we could have been fooled as he had severe TR.
David, our gentleman is unfortunately very sick. His transpulmonary gradient is 5, meaning that his PA pressures that are elevated are likely volume related. He could benefit from some more diuresis. In addition, he has a cardiac index of 1.7. He is in cardiogenic shock. And when looking at his hemodynamics, I would choose an agent that would, 1, help me unload the LV, 2, afterload reduce, being mindful of the severe MR, and finally, 3, let's be mindful of that blood pressure. 85 over 63, we don't have much wriggle room. We could use an inotrope. However, in this moment, I would favor some MCS as first line. We chose counterpulsation with an intra-aortic balloon pump as we await definitive therapy for his valvular pathology.
Wow. This patient's right heart catheterization confirms our initial suspicion of cardiogenic shock. I'm glad he's getting the support he needs with the intra-aortic balloon pump. Okay, let's take a step back and summarize what we've learned so far. We have a patient with recent aortic and mitral prosthetic valve implantations who is presenting to us with recurrent heart failure, which has progressed to cardiogenic shock. He also has a hemolytic anemia, which we have now learned is a result of severe paravalvular mitral regurgitation. We found what we think is the driver of his recurrent admissions. In addition, he has severe tricuspid regurgitation due to leaflet impingement related to a device lead. Now, just a few points to make about tricuspid regurgitation related to device leads. This is actually much more common than we realize. Studies have found that the incidence of lead-related tricuspid regurgitation to be between 10 and 39%, with studies showing that progression of tricuspid regurgitation severity is also seen in this setting. Unfortunately, there are no prospective data to guide the management of patients in this situation. Some have proposed intraprocedural TEE to identify lead location during implantation, but this has not been widely studied. Leaflet impingement can be avoided altogether with the use of subcutaneous ICDs or leadless devices. But these are not options for all patients, unfortunately. Ideally, a fully leadless pacemaker with atrial and ventricular leads will be developed to avoid this complication altogether. David, can you walk us through the management of prosthetic mitral valve complications?
Yes, I think this is an excellent time to review the indications for surgical management of these complications. Currently, as per the guidelines, the indications for surgical management of mitral valve prosthesis complications include severe valve dysfunction with symptoms, severe regurgitation or stenosis, prosthetic valve endocarditis, and symptomatic paravalvular leak. Additionally, asymptomatic patients with evidence of severe valve dysfunction or progressive left ventricular dysfunction may also be considered for surgery. Now, the decision should be individualized based on patient factors, surgical risk, and the expected benefits. And as food for thought, it's estimated that the operative mortality is around 6 to 8% for mitral valve.
You know, guys, one of the things I love about complex valvular heart disease is the whole heart team approach and how some issues are just too complex to fit into the confines of well thought out guidelines. So for paravalvular leak, I just want to also add that percutaneous PVL closure is also an option for some patients. Situations when that definitely would not be appropriate would be when there is concern for active infective endocarditis or unstable valves, for instance, if there is a valve dehiscence or a rocking valve. In a situation where this may be an appropriate thing to consider is depending, one, on local expertise and then also a patient's surgical risk. This is a fairly young patient without too many comorbidities. And I think the added issue of the severe tricuspid regurgitation probably warrants surgical as opposed to a percutaneous fix, but just to be aware that certainly may be an option. What did y'all decide to do for this gentleman?
We decided to go to surgery. He went to the OR shortly afterward for a mitral valve replacement with tricuspid valve repair with annuloplasty. Notably in the OR, the surgeon described that once a mitral valve was exposed, they were able to see that 1/3 of the prosthesis was torn off the mitral valve annulus. 1/3. The pacing leads were also extracted, and the patient had implantation of epicardial pacing wires to avoid recurrence of leaflet impingement of the tricuspid valve leaflet. Belal, how do you do after surgery?
Thanks, Nkiru. Postoperatively, he's done remarkably well and was actually discharged 10 days after surgery. He's largely stayed out of the hospital with no recurrent admissions and followed up closely with our cardiology clinic for further treatment of his valve disease.
Wow, team, what a fabulous discussion. And thank goodness this patient is doing well. Thank you so much for sharing your case and teaching us about prosthetic mitral valve regurgitation.
And now for the expert commentary. I'll introduce Dr. Andrew Wang, who was instrumental in the care of this patient, including completing his right heart catheterization and fluoroscopic interrogation of his mechanical valves. He is a professor of medicine, and Vice Chair of Clinical Services for Cardiology at Duke University Medical Center. He specializes in the treatment of valvular heart disease, as well as hypertrophic cardiomyopathy.
My name is Andrew Wang, and I'm a professor of medicine and cardiologist at Duke University Medical Center in Durham, North Carolina, and I have an interest and focus on structural heart disease. Thanks for asking me to discuss this interesting case. As has been highlighted in the presentation, the patient presented with severe recurrent heart failure symptoms and had a number of signs and symptoms of ongoing hemolysis, including jaundice, unconjugated hyperbilirubinemia, elevated LDH, very low haptoglobin level. Importantly, in the consideration of structural valve deterioration in a patient with a mechanical prosthesis, the patient's INR was not subtherapeutic, although there was initially a concern for prosthetic valve thrombosis as the cause of his recurrent heart failure symptoms because of the elevated transmitral gradient on transthoracic echocardiogram. As has been pointed out, the transthoracic echocardiogram had limited visualization of the severe paravalvular mitral valve regurgitation, but there were a number of clues to the fact that the patient did have severe regurgitation, including the elevated transmitral gradient due to the increased mitral stroke volume, as well as the difference between the mitral inflow stroke volume and the aortic stroke volume calculated by Doppler. The patient was brought to the cardiac catheterization laboratory for urgent fluoroscopy of the mitral and aortic valve prostheses, which demonstrated normal leaflet mobility and opening and closing angles of the mitral valve, suggesting that there was no mitral valve stenosis as the cause of the patient's recurrent heart failure symptoms, and perhaps putting greater attention on the possibility of severe mitral valve regurgitation. In general, transthoracic echocardiography can identify valvular aortic valve regurgitation even with a mechanical prosthesis, but is much more limited for visualization of paravalvular mitral valve regurgitation. So when encountering a patient with an elevated transmitral gradient with a prosthesis, one should always keep in the differential that there may be a paravalvular leak leading to the elevated transmitral gradient. After surgical valve replacement, the prevalence of a paravalvular leak has been estimated up to as high as 18% of patients. The incidence is higher among patients who have undergone a mitral valve replacement compared to an aortic valve replacement. And the incidence is also higher among those patients who receive a mechanical mitral valve prosthesis compared to a biologic valve prosthesis, with a 2 to 4-fold higher risk of paravalvular regurgitation. The majority of cases of paravalvular regurgitation are diagnosed within the first year after surgical replacement, but there may be an increased risk of paravalvular leak over time. There are a number of risk factors for developing a paravalvular leak after surgical valve replacement, including infective endocarditis, as was present in this case, in patients who have significant annular calcification, particularly those with mitral annular calcification, as well as patients with tissue friability, such as those who have been on chronic immunosuppression or those that have had prior valve replacements. There are two typical clinical presentations for patients with paravalvular regurgitation. Number one would be heart failure, as was seen in this case in patients who have severe paravalvular regurgitation. And the second presentation would be possible hemolysis. These can be present in the same patient. Hemolysis, however, may be present even in the absence of severe degree of paravalvular regurgitation. It should be noted that in patients who have had a mechanical aortic or mitral valve replacement, laboratory studies will often suggest some degree of ongoing hemolysis, such as a relatively lower haptoglobin level and mildly elevated LDH level. But obviously, the degree of the anemia and other findings would suggest the severity of the hemolysis to pursue other additional diagnostic testing to identify if there is a significant paravalvular leak. There are two treatment options for patients who have clinically significant paravalvular leaks. The first treatment option is redo surgery, but this is associated with a higher operative mortality of 6 to 12%. In the majority of cases that do undergo redo surgery, about 75% of them can be primarily repaired, meaning that the paravalvular leak is closed without removal of the implanted valve replacement and need for another prosthesis. Transcatheter device closure with a vascular plug may also be pursued to close a paravalvular leak. There are certain contraindications to attempted transcatheter vascular plug occlusion, specifically patients who have active infective endocarditis or those that have a very large paravalvular leak that would encompass more than 1/3 of the circumference of the annulus of the prosthesis. In this patient's case, the size of the paravalvular leak was quite large, and it was felt that device closure was not going to be successful in reducing the degree of mitral valve regurgitation or the patient's risk of future heart failure. Transcatheter closure of a paravalvular leak is successful in about 70% of cases, and it is important to reduce the paravalvular leak as much as possible, particularly in patients who are undergoing the procedure for hemolysis, because even a small paravalvular leak area may lead to hemolysis. One limitation of closure of paravalvular leaks is the lack of dedicated devices for this procedure. So we will often use a combination of catheters, including a steerable catheter, to allow crossing of the defect with a wire and catheter, and then delivering a vascular plug across the defect. During the procedure, it's very important in a patient, especially with a mechanical mitral valve prosthesis, to assure that there is no adverse impact on the opening or closing of the mechanical leaflets. I'm very glad that this patient had a favorable outcome after redo surgery for his paravalvular leak. I think the take-home lessons from this case are to consider a paravalvular leak in a patient who has had a mechanical valve replacement and who has unexplained recurrent heart failure or evidence of hemolysis, and to pursue the diagnosis with transesophageal echocardiography. Thank you again for asking me to discuss this interesting case.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Adriana Mares, intern in the CardioNerds Academy Health Tausic and student researcher at Yale Medicine. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.